Hello and welcome to the Auditing Antics podcast. So, Michelle, of course, you're going to make me laugh right away. For those of us that are on audio and you can't see us on video right now, Michelle chose the introduction as the time to take a drink, and it was pretty funny in the camera. Um, we're like the kind of people that, when they say that you can't sit next to them in church or in a serious moment, that's going to be us, because we'll just be sitting there laughing, shaking up and down, you know
That's how we
misbehaving.
learned our silent laugh, was sitting next to each other in church growing up, because we could not let on that we were not paying attention.
Yes, exactly. So today we're going to be talking about our key phrases, or those buzzwords that we see in documentation, that as we're reviewing the notes, we can tell that that physician or practitioner thinks that that's what's making that a level 4 or a level 5. And whether the encounter supports the level of service or not, the fact that that phrase is there means nothing to us from a coding perspective. So we want to talk about, what this looks like from a review perspective, but then also, Michelle, I'm finding that a lot of people have trouble bringing these types of issues forward to have conversations. This is a really good example of where someone may see this as a problem and other people don't want to address it. They just want to leave the practitioners alone, or maybe there's a physician, they don't want to hear it, they just do what they want to do, that type of thing. So let's break it down first from that perspective of when it's happening, you know the fact that we're just going to ignore it, essentially.
hmm
It's not going to hold any weight.
So the the hard part that I think I see is it's not so much people ignoring it, it's people not understanding why it doesn't work. And the answer is to never just ignore something. You have to be able to bring your concerns to the table. There needs to be a discussion about it. Um, it it can be pretty difficult, I think, to be that person who identifies something and is just basically brushed off. But you need to keep trying, and you need to keep going to that next person. There's always somebody else that you can bring this concern to. Um, I know in the past I've been completely brushed off with concerns, or I've had a different thought process about how I leveled an E&M service, and basically was told one of two things. And one was told that why couldn't I just trust their years of of experience, and then I was further labeled as a troublemaker when when I wouldn't just accept. So I mean, in the end, it became very apparent that that was not the place for me. I hate to say that, but there's always other people. So that's more so like within your own department. But when it comes to providers, I mean, you really can't just allow this to go by the wayside and ignore it. Unfortunately, compliance is not optional, and it can be difficult to get everybody on board, but you have to have conversations with the appropriate people. And when you're following your chain of command, you just keep following it up, because compliance isn't an option. And I mean, I'm not really interested in what you do or don't want to do when it
Mhm.
comes to that kind of thing. Obviously, that's not how you start those conversations. But I think that a lot of times when there is things like a provider brushing it off, there's a deeper issue there, wouldn't you say, Stephanie?
Yeah. Yeah, for sure. And, it's one of those things. I've been asked this question before. I'll be meeting one on one with a physician after an audit, and they'll say, well, can I just create macro statements that say that this is a moderately complex patient? And a lot of times when I see these statements, that's really where it becomes a problem, because underneath the treatment plan that clearly supports low complexity, they'll say this is a moderately complex patient due to, and then they'll list out other things that are bullet points in the grid that we have from AMA.
Mm-hmm.
Especially with highly complex, there's a lot of times
Yeah.
we'll try to do that. And it's one of those things where I often wonder, depending on the structure of the organization, how it got to that point when there is a compliance department, there is a coding department. There's times where I'll go back and talk with the contact people that I have for a particular audit, and they'll say, oh yeah, that's a problem. We know that that's happening. That's an issue. But what if the organization doesn't have a coder who looks at every note? What
Mm-hmm.
if it's that physician's responsibility to code that, and they're constantly putting out a 4 or 5 because they think that their macro statement supports that?
Mm-hmm.
That's where we're going to have a larger issue, because nobody's there to catch it, and it's just happening even though we know that it shouldn't be.
Mm-hmm. Yeah. And I think the important thing to remember with these, if you are somebody who is a coder and you are seeing this, is AMA has given us very clear definitions in the guidelines regarding some of these phrases. So you might be seeing this and saying, great, this says specifically in here, acute complicated illness. However, they have an ear infection and we're given reassurance, things like that. But we have very clear definitions. And this is how I basically combat when somebody says, well, it says this is a life-threatening, poses threat to life and function right here, or requires intensive monitoring, but what you've documented is a stable chronic condition. Your documentation did not support the severity that you're implying with this statement. The work you've documented did not support the complexity that you are implying with this statement. So not only does documentation doesn't need to show those specific words to support it. It needs to show the work that you're doing and the severity of the patient. Putting in those phrases means nothing when it's not backed by the work of the encounter.
Mm-hmm.
And that a lot of times is forgotten. I think that they think because they've said these keywords, like I said, I refer to them as ring-a-ding-dings, that they have
Mm-hmm.
supported it and checked a box, and now you know what? I can just bill this level all the time and I don't have to worry about it. I am compliant. No, you do have to worry about it. The other area that I see this in a lot, Stephanie, is with critical care as well. And you'll see in their critical care statement that, this was all of those keywords. I can't think of them off the top of my head for some reason, but life threatening, multi-system organ failure. And when you read the note, they're reaching baseline, they're
Mm-hmm.
or yes, maybe the patient is critical, but the provider isn't demonstrating that life and organ supporting interventions in their note, things like that. So you can say all of these phrases, use all of these canned statements, but if your documentation doesn't back up the work that shows that this is the true severity and complexity of the patient in your treatment, it means nothing.
Well, and I think this is stemming from a couple of different areas. First, one thing that I find is when I work with physicians and practitioners that have been in this industry for a long time, there's frustration on their part, but a lot of them don't even realize what that shift meant with 2021 and 2023 guidelines.
Mm-hmm.
So when I know that they don't understand the shift, I can pretty much pinpoint the fact that they're thinking the way we used to look at medical necessity. So, for example, we would heavily look at a presenting problem and say, okay, what is the risk or the severity of this presenting problem? And that could be a driving factor of an E&M service when we used to have to play around with all that subjectivity
Mm-hmm.
of medical necessity. We still have that present where we still have to look for that necessity, but we have a little bit more of a framework because now that's housed into our first column, our first element of MDM, if that's what we're looking at. So that's one thing. It helps me to understand the viewpoint of the other person that I'm working with to try and bridge the gap and figure out, okay, why are they thinking that this alone drives that higher level of service?
Mm-hmm.
So a lot of times when I see the buzzwords of this is a moderately complex patient or a highly complex patient, that a lot of times is driving it because that's what we used to look for. Now, in addition to that, like you were saying with critical care, I always think about some of these different projects I've had over the years where one, there was a client who went through an external review. They completely bombed it. I think it was a TPE review where you go through the different levels. And if you fail the third level, that's going to be much worse. You can be referred up. So in this situation, they kept failing it. And when you look at the documentation, there was just that statement that said, I cared for this critically ill patient. I spent 35 minutes and that type of thing. And to your point, Michelle, when you look through the rest of the note, the patient's stable, they're doing well, they were extubated, they're, doing fine on room air, they're getting ready and coordinating, transferring them to another unit. And it just doesn't add up.
Mm-hmm.
And I think one thing that can be difficult, depending on where people are at in their career at this time, it can be really difficult to try to differentiate in these ways as a coder, for example, because you may not have seen all of these other examples. You may not have as much experience yourself to try to articulate this to the provider. But at the end of the day, the documentation, as much as physicians and practitioners do not like to hear it, the documentation is not there only for clinical purposes.
Mm-hmm.
And, that's where it's really hard to find that balance because that's their main focus. Our main focus is coding and billing, and we are instructed very specifically that even if we have a form of clinical training, we cannot apply that.
Mm-hmm.
So when we're talking about these things, I just want to make it clear to the audience, it's not Michelle and I going in there and saying, "Oh, that's not critical care." Or, we're not saying, "Oh, well, they didn't support that organ system properly." It's more on a higher level, a more basic level. Is the
Mm-hmm.
note showing that the patient was critical? As a part of AMA's definitions and guidance, you can go into the CPT manual and look at critical care, and it talks about the fact that the patient is highly complex. They require, critical level care, highly complex decisions. So, it's not that we are going to be picking and choosing what is
Mm-hmm.
highly complex. We're looking for them to show us that work in their note. And I'm a very firm believer in the coding industry that if we don't have free texted documentation, it is extremely hard to support moderate and almost impossible, if not impossible, to support high complexity because we don't know what they're thinking clinically
Mm-hmm.
and we're not allowed to make assumptions.
Yeah.
So we can take these things and have conversations, but we cannot just take that leap for them and say, oh, well, they documented critical care, so we just have to bill that out because they said 35 minutes of critical care. We can't be
My,
blind either.
my favorite phrase is please bill 35 minutes of critical care with their phrase. Oh, it's like, thank you for asking so nicely, but no.
Yeah, yeah.
But one thing that I do want to say is instead of focusing on these phrases that appear in our MDM tables, start focusing on the definitions. Instead of giving the very high level example, instead of saying acute illness with systemic symptoms. Focus on the definition of that, because clinically, a systemic symptom is very different than what the AMA definition of systemic symptom is. And I think if we start focusing
Well,
on
the
the
risk of the
definition,
symptom.
well, yes,
Yeah.
the
Yeah.
definitions of if we focus on the definitions instead of that phrase that is just really supposed to be the reminder. And I think sometimes we forget that we have to think outside of the box, and that only those things listed isn't the only thing that supports high complexity. It's not the only thing that supports moderate complexity. We have to be able to think outside of the box when it comes to that. But focus on the definition, and I think that clears up some of that wishy-washiness that we sometimes experience, and just give, let them peek behind the curtain, because that's what they've given us with these definitions. And same thing with critical care. I know a lot of MACs have some pretty good information related to that on their websites, where they expand a little bit more into those definitions and things like that, that can help give some insight to our providers that we're not telling you this patient isn't critically ill. What we're saying is it just isn't documented. And
Hmm.
sometimes I think our providers, especially, well, it applies inpatient or in the office, they are on a time crunch a lot of times, and documentation is a thorn in their side and time consuming. And so they may not document everything that they did that day. And
Hmm.
sitting down and having a conversation, asking them what they did and things like that, I think kind of make it a little bit more eye-opening, where the two can come together and you can kind of have that light bulb moment of, oh, well, you need to tell me this in your note, and not just assume that it's implied, or remember that these are the important things to show and things like that in your documentation.
Well, and I have a particular example I always think of was something like this where we have that disconnect and we don't know what they're thinking. So there was a time where I was reviewing a urologist and I was doing an audit, and the patient came in. They had, I'll let you finish drinking in case
Sorry.
you laugh. Well, in case you laugh, I don't know if you will,
Oh.
but they had the patient came in again seeing a urologist, and they had fallen off their porch. So they'd fallen down steps, which yes, I probably would have laughed if I saw it and then go for help after. But they fell off, and they're coming into the urologist and they're saying, they've already had all of their workup, they went to the ER that day, all of these things, and the patient says they're doing well, and I'm like, for the life of me, cannot figure out why the urologist is focusing so much on this fall when the patient hurt their rib. So then there's reference in there to a rib x-ray. I can't remember at this point if he was interpreting the rib x-ray or if he was ordering another one. But I'm looking at this note. He's saying it's a level 4. I don't see it in documentation. With my lay, understanding, I also can't piece this together and figure out what the heck a urologist is doing with a rib. And then I have a conversation, and he's telling me all of these things about some of these symptoms the patient had and how he had a high level of concern that the rib fracture impacted a kidney. And it's like, okay, well, you left every bit of that out of there. I have no
Yeah.
idea that that's
This is
what you were piecing together.
this is
So
my thought process. We drill thought process.
yes. Yes. And as he's verbally explaining it to me, I'm like, yes, of course that's complicated. And, going between low and moderate for uncomplicated versus complicated injury, acute symptoms. I was like, okay, then yes, absolutely, that I can see that. But you have to show that in the documentation.
Yeah.
So, we, one of the other things too that I think it's important when we have conversations like this is to talk about the impact that the EMR can have. And,
Mhm.
right now as well, there's so many people that are implementing in like ambient scribes with AI software or just a lot more automation. We have a lot of macro statements, templates. Those have been around a long time. But this is also an area where these phrases can come into play and it causes quite a big issue. So, Michelle, one of the things that I think about with this is when we have, for example, an EMR system that has an entire paragraph for every single thing the provider's ordering, regardless of the risk or, what's playing into that. And,
Mhm.
there's been times where I'm auditing, for example, modernizing medicine is an EMR that is, you know, they do this all the time. And some people don't like to name that particular software product, but let's just say it. They have a lot of things that are automated. It's not a bad thing, but you have to look at how it's being used
Mhm.
because remember, we've talked before and I've put content and articles out there and everything about AI in the industry. It's not a bad thing it's being used, but once somebody develops that, it's not hands off and then whatever happens happens. You have to pay attention to how it's being used, what the outcome is of a level of service. And I always think about that particular software because there's times, for example, where I'll see that whole paragraph for Tylenol, and all of a sudden the provider's putting in moderate, or it'll talk about all of this risk for an injection, but it doesn't talk about the patient's personal risk, and we
Yeah.
don't have moderate treatment plan risk. So I understand what systems like modernizing medicine are doing, and there's a lot more of this happening with the implementation of AI and different products like that. But again, it just shows why external audits and monitoring of what's happening day to day is so important.
Yeah, and I would definitely wait, I just lost my train of thought. Sorry. Okay, so with the EMRs, this is what I was going to say. A lot of times when it comes to templates and things, and this applies to like how we still have the SOAP note, even though we've had a drastic change, and how we look at E&M services. I often wonder if we just sat down and said, well, what was the purpose of this? Just explain to me why you documented this and figure out, was it from something clinical or was it because they thought it did something from a billing perspective?
Hmm.
And I think we would find that sometimes, yes, there are some clinical things that are in there that were like, oh, this was pointless, from a billing perspective, but it means something clinically, and
Hmm.
we just don't recognize that. And I think that if we had that conversation, it would help a lot with things like overuse of templates, overuse of copy and paste, because in their minds, I think they're still stuck on that. Got to have all these reviews of systems, got to have this physical exam in there, we've got to check these boxes, when really we just need to know what you did. It's no longer bean counting. Did you get this many in your HPI? Did you do the histories? Did you do, to get that comprehensive history, comprehensive exam? And I think if we just sat down and kind of meshed through everything and figured out what they document from a clinical perspective and what they document from a perspective because they think it is needed for billing, we would find a lot out. Um, because a lot of times those templates, like overuse of templates about Tylenol, for example, um, they really lose meaning when it appears on everybody. Um,
Right.
you know what I mean? Like, this, you didn't tell me why this patient, I mean, obviously, we know Tylenol has the risks on it and stuff on the label, but you got to tell me why this was relevant to this patient, not to put it in here as a
Yeah.
as a check.
Yes, yeah. And that makes me think about the fact when, for example, there's a lot of psych nurse practitioners that I'll work with that have, solo practices and they've been in business for a year. They may get an external audit, they get a little nervous, or they get record requests, they get a little nervous. And I'll work with them and they'll say, well, we didn't learn any of this. When they're in college, when they're doing different training programs, this is not an area that they're focusing on. So they're going into this whole process blind, essentially. They
Mm-hmm.
know exactly what they learned from a clinical perspective, what needs to be seen and what should be there clinically. Depending on specialty, especially with psych, they'll know different things from a legal perspective at times. But the component of billing is just kind of like a shot in the dark, right? They're
Mm-hmm.
taking a stab at it. They're not completely sure about what it is that needs to be there. They know that their patients are complex. They know that they're managing medication, but outside of that, they don't know what that needs to look like in the note.
Mm-hmm.
And to your point, there's times where after I finish an audit like that, I'll say, okay, how about we set up one more meeting and let's do a screen share and let's look through your charting process. Let me just watch you chart one patient where real time I can ask you questions about why you're putting something in there. And, I remember with one particular person, it was a situation where their printed note was over 10 pages. And they're like, why is this over 10 pages? Why is all of this in here? Why is this needed? And by showing a focus on what we need from the billing side, the coding side, and compliance, they can then think real time about the clinical piece and what they know they need in there for clinical. And it can help pare down and reduce some of that
Mm-hmm.
burden because it's always going to be here. It's that necessary thing that not everyone wants to focus on, but that's a way to drill it down and not have it be so overwhelming.
Mm-hmm.
Don't show up to these meetings and these sessions or call and ask for a meeting about a situation like this and then just say you're doing it wrong and walk away. You need to
Yeah.
be able to be there as a part of the solution as well and lessen the burden, lessen, that unknown that they're facing so that it's easier for everybody going forward.
Yeah. And I would say don't ever educate from a standpoint of like you need to add this into your note in order for this to be supported. You should be educating from the standpoint of document the work you did, and then what's supported is what's supported. I mean, you can't go wrong by just documenting the work you did. And that's where I think sometimes um, it can go wrong, because there are some people that will go in there and say, this is what needs to be in there. And then that's taken as, oh, if I just put this specific thing in there, I can always bill a level
Mm-hmm.
5 now. Or, I can remember early on, this was under the old guidelines, where I worked, had hired this company that had a physician who taught physicians how to E&M code. And here I am, just a new baby coder, and he's sitting there saying, you just document these things. I'm sure you're doing this. Just document these things, and then you can get to this level. And I'm thinking to myself, what? So, the one guy was like, oh, so if I start independently interpreting every x-ray, I can bill a level 4, like that kind of thing. And it's like, well, would you have done it before? Do you need to do it now? Like, you don't just do something. And I also don't like when people are like, we don't need this for billing. We don't need this for billing. Don't document that. It's like, no, this is also for clinical purposes as well. Like, we aren't the only people who use these notes.
Mm-hmm.
So, just be part of the team. And like you said, don't go in there like you're there to punish them or they've done something wrong. You're there to be on their team and help them. And like you said, reduce the burden, but make sure that the recommendations you're giving are actually going to reduce the burden and not cause more burden down the road.
Yes. Yeah. I know, and that's always really hard to balance. But if you think about things ahead of time and go in prepared with a plan, that's also why I always like to talk first about a scenario, then we talk about that scenario from a coding perspective, because
Hmm.
we can't say that every time this diagnosis is this level. I had a meeting with a mutual client with Terry Fletcher the other day. I was working a project with her in a large pediatric organization, and there was a large focus on level 5 services. And we had a whole conversation where, just because this is pediatrics, yes, these are highly specialized positions. These patients are more rare in some situations. The conditions that they have, all of that is very complex, but it doesn't automatically equal a 5. So, we've got to make sure it's not focusing on, the set of, oh, these things are here, it's always going to be a 5. Remember, it's not patient setting, patient diagnosis, provider specialty, location where the patient's seen. None of
What
that
could
drives our
happen down
coding.
the road?
Yes. Yeah. Yep. And when I say none of that drives our coding, what I mean is none of that drives the risk automatically. We
Yeah.
still have to go through the process. We could still support a lower level of service. So we have to make sure that things are not automated on our side. So if you have people that are overusing these phrases, setting up macro statements, thinking that that's the end all be all in working, I would just suggest sitting down, having a conversation. Start within your department where you're identifying it. Look to who else you can have these conversations with. If you're a coder, talk with your lead, talk with your supervisor. It will then be their responsibility to take it on from there. But, it's something where regardless of how those conversations occur, when we're doing our work as a coder or auditor, we have to make sure we're not giving credit for things like that. So we can know it's an issue. We can ask for it to be changed. If you continue to see it in there, just bypass it. Don't account for it. For me, if I'm doing an audit and it's in every note I'm looking at with a specialist, which happens quite often, I ignore that part. I look at everything else, and then that's a large part of the education that has to come afterwards. So either way, we can mitigate that risk. Where it's going to be a bigger issue is if it's happening, there's not someone coding, the physician chooses all 4s, all 5s because they have the statement, and then they go out the door.
Yep. Because they're definitely going to stand out on those
Yes.
graphs.
Yep. All right, so we're going to go ahead and end it there for today. Next week, I hope you join us back. We're going to be diving some into remote patient monitoring. So we've had some changes in that space in the industry. There's a lot that's happening this year in the beginning of 2026. So we're slowly trying to tackle some things each week on the podcast here. But we're going to focus on RPM next time, and not just the changes in the codes, but what people need to be looking for when they are looking to maybe partner with another organization. RPM is largely becoming an area that people think is essentially passive income, and they want to have someone there to do the work for them and not have much oversight or much, hands-on work for themselves. And it's really creating a lot of risk. So we're going to tackle that, break it down, let you know what you need to be aware of if you are looking at outside organizations, and how to monitor and make best decisions for your group as you can, informed decisions. All right, we'll see you back next week.